Bismillahirrahmanirrahim. Assalamu alaikum to all and good morning. I am Dr. Sama bin Shaheen, resident virology, and today we will be discussing the topic of female dysuria and UTI. As we all know, UTI is very common and we encounter a lot of patients in our OPDs and emergency with complaint of dysuria. So it is important for us to know what is dysuria and urinary tract infection so that we can adequately manage these patients. So, introduction, dysuria literally means abnormal maturation. It is defined as any change from the normal sensation or function experienced by women during their voidings. There are two types of dysuria. The first one is the burning sensation during voiding. It is the most common one and it is also most uncomfortable for the females. The second type of dysuria are basically the obstructive low urinary tract symptoms, which include hesitancy, intermittency, straining, and dribbling. It is less common, but if the obstructive type of dysuria is not properly managed, it can lead to bladder dysfunction and hydronephrosis. So, in order to manage dysuria, it is very important to understand that dysuria can arise from causes which is inside the lower urinary tract, that is in the bladder or urethra, and also external to the urinary tract, that could be from the vagina. So, these type of dysuria are called vulvar dysuria. So this is a chart showing the common causes of dysuria, and it's a very important chart, and you can see on the top one is the urinary tract infection. Apart from that, there are other causes as well, such as urethritis, urogenital tuberculosis, vulvovaginitis, and then there are causes like hypoestrogenism, hypersensitivity to products for genital hygiene, post-radiotherapy cystitis, urethral diverticulars, urogenital neoplasm like bladder, urethral or vaginal carcinomas, bladder stone, and intravesical foreign bodies, and bladder pain syndrome, interstitial cystitis. So these are the causes of dysuria. So keep this slide in the mind. We will be discussing further these entities. So let's discuss a scenario. It's a scenario, and if you are standing in an OPD and a patient present to you with complaint of 36-year-old female. She has married, no known comorbid, and she presents with complaint of suprapubic pain, burning maturation, straining, intermittency, and difficulty in passing urine for the last 1 week. She has no history of fever, no past medical and surgical history. She is vitally stable and examination is unremarkable. So how will you proceed? Anyone in the audience? It's a very common presentation and we encounter a lot of these patients. So just initially, how will you proceed?
History examination.
Yes.
Examination.
Yes.
And then go towards the investigation.
Yes.
Urine bleed.
Yes. So yes, you are right, quite right. And this is basically the algorithm. A patient presenting to you with complaint of burning discomfort during maturation. So as you rightly said, we should do the history, should take the history and physical examination. And if on examination there is a history of any flank pain and concomitant history of fever or vital sign abnormalities, then most likely the patient will be having acute pyelonephritis or urosepsis. And that in that case, we should admit the patient in emergency.
One thing I would like to mention in the examination that urethritis is a very well-known cause of dysuria.
Yes.
And we do not examine female patients and we do not see the urethra at all. And again, vaginal discharge you have already
Yes.
mentioned is again an important cause of urethritis and dysuria. That also we do not see and examine in the.
Yes, I'm quite.
Another thing is that this non-gonococcal urethritis like chlamydia, trachomatis, and other, they do not usually present with discharge, and we do not have the facility to culture these organisms.
Yes, quite right. If on history and examination there is no concomitant fever or flank pain and vital sign abnormalities, we should do a urine dipstick test and a culture. Urine dipstick is a quick test, and if urine dipstick shows nitrite positive, then most likely the etiology will be a urinary tract infection, and an empirical antibiotic treatment should be started. If on urine dipstick we find leukocytes are positive, but nitrites are negative, we should wait for the urine culture. If urine culture is positive, we should start the specific antibiotic therapy. If a urine culture is negative, then it's basically sterile pyuria. that is the leukocyte are positive but urine culture are negative. If on history there is a positive history of urethral discharge and or itching sensation, the likely cause would be a urethritis. So we should send the urethral swab. And if on urine dipstick there is acidic urine pH or there is history of tuberculosis or exposure to tuberculosis, patient could be having genitourinary tuberculosis. So test specific for tuberculosis should be sent. If the urine dipstick shows both nitrite and leukocyte are negative, we should wait for the urine culture, and if urine culture is positive, we should start a specific antibiotic therapy. If urine culture is negative, then most likely the cause of dysuria is non-infectious. So we could think of the causes like vulvovaginal disease, and we should further investigate and treat the patient.
Will the urine culture positive or negative in 100% of cases? There might be a present infection, and we might get a urine CS node growth. It happens oftentimes. But the culture comes out to be negative, but very minor percentage of patients still have an infection.
So how do you diagnose that infection?
Sometimes there is in urine there is bacteriuria, but when you culture, they say no.
So you have to have two other things. One is leukocytes, esterics, and
Nitrites.
So that makes your diagnosis a little bit closer to positive culture. So you have to have a very strong evidence before starting antibiotics. That's the main theme of this presentation. Simply pyuria doesn't signify or qualify for antibiotic therapy.
Yes.
Because if we do it like this, then we'll be having nothing left for us for UTI. And now, at the moment, the antibiogram is such that there is no antibiotic left for UTI to be treated. And this is just because of the reason that we have been treating pyuria with antibiotic and not thinking of all these things. So at least you do mental exercise. Put yourself forward, make your evidences more robust, and then start antibiotic.
This is symptomatic pyuria and we do not have culture with us.
Yeah. It should be symptomatic pyuria plus these two things, leukocyte, esterase, and nitrite. And if culture is negative, then you qualify this patient for antibiotic. Otherwise, not.
So let's start with urinary tract infection, which is the most common causes, and there are various types of urinary tract infection, like uncomplicated, complicated, first or isolated UTI, what is unresolved infection, what is recurrent UTI, what is domiciliary or outpatient UTI, what are the nosocomial or healthcare associated UTI, and asymptomatic bacteriuria. We will be discussing all these UTI in the coming slides. So started first with the uncomplicated UTI. Uncomplicated UTI is defined as an infection occurring in a healthy patient with structurally and functionally normal urinary tract. The diagnosis, as we suggest, is suspected on the basis of the history like dysuria, frequency and urgency, and there is absence of any urethral or vaginal discharge. The mainstay of the diagnosis is of course the urinary culture, and colony count of exponent 3 colony forming unit per ml of pathogen will confirm the diagnosis. The urine culture is very important because in urine culture we not only identify the bacteria causing the infection, but based on its sensitivity pattern, antibiotic therapy could also be started. So the most common causes of uncomplicated UTI is E. coli, followed by Staphylococcus saprophyticus, Klebsiella pneumonia, and Proteus mirabilis.
What I have observed in OPD, after E. coli, we most commonly see Klebsiella, and then after Klebsiella, we see Pseudomonas, not Staphylococcus saprophyticus.
That might be different from one geographical area to the other.
I'm talking about our other OPD.
This is just a chapter from a book, so
Yes, sir.
it has to be taken that.
There are certain risk factors for uncomplicated UTI, like sexual intercourse, use of spermicide, a new sexual partner, a mother with a history of UTI, or history of UTI during childhood. So this is the regime for antimicrobial therapy in uncomplicated cystitis, and there are certain antibiotics which can be started, like the first line agents in women include fosfomycin, which is 3 grams single dose, and it's given for 1 day only. Nitrofurantoin can also be given, nitrofurantoin microcrystal 50 to 100 mg 4 times a day for 5 days, nitrofurantoin monohydrate microcrystal 100 mg BID for 5 days, nitrofurantoin microcrystal prolonged release 100 mg BID for 5 days, and pivmesalinum 200 mg TID can be given for 3 to 5 days. These are recommended only in women with uncomplicated cystitis. Alternative include cephalosporin 500 mg BID for 3 days. We know that E. coli are most common causes of uncomplicated cystitis, and if in our locality their local resistant pattern for E. coli is less than 20%, trimethoprim can be given 200 mg BID for 5 days, but it should not be given in the first trimester of the pregnancy.
So in our case, as Dr. Rusana was saying, maybe E. coli is not less than 20%.
It's more than.
It is more than 20%. So, and that is local resistance. So we have got a very high resistance pattern as compared to what any chapter in a book would say. So the thing is, for instance, if we are like 50 people in this room, and out of 50, 49 are convinced that they should follow a pattern, a scheme in a particular area, and only one of us is not following that regime, and if that person is in the OPD confronting maybe 50 patients, and on every patient he is writing an antibiotic without considering any scheme, then that is a call for havoc. Because once that thing is practiced time and again by a lot of people, you will not be having any sort of sanity in your practice. So what we are talking about today is to follow a regime, whatever that regime is, but follow a regime totally, not only one person or two persons, but the whole group. And we all have to be convinced, because only one of us can make the water dirty.
Yes, sir.
What is the rationale for putting phosphomycin on the top and nitrofurantoin is the second choice?
And that can be talked about with our own infectious control team.
I've requested Dr. Sunil, he might be here in any time soon.
How do we choose whether we should start with nitrofurantoin or phosphomycin?
So we'll just stay put for Sunil.
Yes. Combination of trimethoprim and sulfomethoxazole can also be given 160/800 mg BID for 3 days and should not be given in the last trimester of pregnancy. Treatment in men also include combination for 7 days, but we are discussing today the female dysuria. So the next one is the complicated UTI. Complicated UTI is defined as infection which is occurring in a urinary tract that is structurally or functionally abnormal, or the host is compromised, or the bacteria have increased virulence and antimicrobial resistance. It is associated with factors that increase the chance of acquiring bacteria and decrease the efficacy of the therapy. Complicated UTI most commonly occur in men, and these patients should be treated based on the results of the urinary cultures. So common factors associated with complicated UTI. So you can see there is abnormality in the urinary tract. For example, obstruction at any site in the urinary tract, like a stone or the prostate, enlarged prostate, any foreign body, if patient has incomplete voiding, if there is radicular reflux, if there is a recent history of instrumentation, UTI happening in a male is always a complicated UTI. In pregnancy, if the patient has diabetes, if there is immunosuppression, and the healthcare associated infection. These are associated with complicated UTI. The organism causing the complicated UTI are more resistant as compared to those causing uncomplicated UTI. Enterobacteriaceae is common 60 to 75%, with E. coli again the most common pathogen, but certain additional organisms like Pseudomonas, Serratia, Enterococcus species are also found in complicated UTI. So the principle of complicated UTI treatment is, so it is important for us to understand that we do not only need to treat the urine culture, we should eradicate the causes which are causing the complicated UTI. If there is any obstruction, we should relieve it. If there is any complicating factor, we should address that as well. Because unless and until we do not treat those causes, the UTI will recur. So we should manage the risk factor or the anatomical or urological abnormalities which are causing the complicated UTI. If the patient presents with systemic symptoms like vital sign abnormalities or the history of the fever, the patient should be admitted and treated with intravenous antimicrobial regime. The regime could be aminoglycoside with or without amoxicillin, second or third generation cephalosporin, or broad spectrum penicillin with or without an aminoglycoside. Alternatively, if the urine culture is not available, in empirical therapy with broad spectrum antibiotic, fluoroquinolone, third generation cephalosporin, and aminoglycoside should be started and should be extended for up to 10 to 14 days. So now discussing the further infection which I showed in the initial slide. So what is first or isolated infection? First or isolated infection occurs in an individual who has never experienced an episode of UTI or has one remote infection from a previous UTI. So it is called first or isolated infection. Unresolved infection is the one which has not responded to antimicrobial therapy, and it is caused by the same organism with a similar resistant profile. So we are given antibiotic and the infection has not been resolved, and it is caused by the same organism and similar resistant profile, that is the unresolved infection. Domiciliary or outpatient UTI occurs in a patient who are not hospitalized or institutionalized at the time they became infected. They are at home. The domiciliary UTI are caused by common bowel bacteria like Enterobacteriaceae or Enterococcus faecalis, and they are susceptible to the common antimicrobial agent. The nosocomial or healthcare associated UTI are the complicated UTI and occur, of course, the patients who are admitted in the hospital. And it is caused by resistant species like Pseudomonas. So these UTI are caused by the resistant organism. Recurrent UTI. Recurrent UTI are very common. It is defined as the UTI occurring after documented successful resolution of the previous infection. Recurrent UTI occur at a frequency of at least 3 times per year or 2 UTI in the last 6 months. There are 2 types of recurrent UTI. First is the reinfection and the second is the bacterial persistence. Reinfection is defined as a new infection which is associated with the reintroduction of bacteria into the urinary tract from outside. The bacteria enter the urinary tract from outside. That is called the reinfection. And the bacterial persistent is caused by the organism which re-emerge from a focus within the urinary tract. For example, an enlarged prostate or infectious stone. So bacterial persistent is caused by the organism which are present in the urinary tract itself and cause the recurrent UTI, of course.
Maybe a catheter.
Yes.
Maybe a catheter.
So diagnosis is by urine culture, as we all know. The workup in routine UTI is not routinely recommended, but it can be done. For example, if we are suspecting any bladder growth or if enlarged prostate, a cystoscopy is recommended. If we are suspecting any stone, then imaging by CT KUB or ultrasound KUB should be requested. So these are the risk factors for recurrent UTI, and you can see it is quite different in young and pre-menopausal women and post-menopausal women, because we know that in the pre-menopausal age the hormonal profile and the physiology of the female is quite different, and after the menopause the physiology of female changes. So in the pre-menopausal woman, the risk factor for recurrent UTI is the sexual intercourse, use of spermicide, a new sexual partner, a mother with a history of UTI during childhood, and blood group antigen secretory status. In the post-menopausal or elderly women, the history of UTI before menopause, incontinence, atrophic vaginitis secondary to estrogen deficiency, a cystocele, an increased post-void residual, again the blood group antigen secretory status, urine catheterization and functional status in the elderly institutionalized women. These are the
Just yesterday I posted a photograph on Infogram. All of you can refer it, and that is the normal flora of genital tract of a female. And if that flora is disturbed by any means, by means of any lubrication or spermicide or whatever, then that leads to actually something called malignancy. So just the change of microbiome can lead to malignancy. That's the lesson of that small photograph. So if you all go back and see yesterday's post, you will be able to understand how it is important. We humans have got a lot of bacteria inside our body, and that is in the form of symbiosis. If we change it, if we change the flora, we change the symbiotic pattern, and it becomes a pathogen rather than a commensal. So it is very important to understand one thing, that we are not in the process, if we are doing any surgery, any kind of surgery, we are not in the process of thinking that there should be no bacteria, sterile environment. Sterile is not the goal. If that is the goal, then we have a lot of these things which we can't just predict or control. What we want to have is no pathogen, but we should have commensals. That is very important for normal physiological beings.
Yes, sir. So it is written blood group antigen secretory status. Anybody have idea what that means? Yes. Basically, in the human population, 80% people are secreted based on the blood group. What is secretory status? Is that in secretory status in a normal population, it secretes some blood antigen into the secretions like saliva or urine. So those secretor patients who secrete blood antigen in the urine, they are more likely to have cause a UTI. So blood group secretory status is basically the typical antigen from the blood which is released into the fluid like saliva and urine and other organs. I mean,
It happens in every person. Or
80% of the population are secreted and 20% are non-secreted. So I found it in the internet. In general population. So
is this related to ABO?
it is related to ABO of course. Yes. So management of a recurrent UTI. So we all know prevention is better than cure. Of course, we can treat the patient, but it is important to prevent the UTI from happening. So it is very important to prevent the recurrent UTI from the happening. And how can we do that? Is that we have previously identified some risk factors associated with UTI. So we have to address those risk factors so that infection does not occur. For example, abolishing the use of spermicidal agent if the patient is diabetes mellitus, which should optimize her glycemic status. So in that case, the recurrent UTI will not occur. And if there is a patient having urinary incontinence, so we should treat the urinary incontinence. So in that way, we can prevent the infection from occurring. It is also stated that in postmenopausal women, vaginal replacement therapy with estrogen has shown a decreasing trend toward preventing a UTI. Prophylaxis with cranberry extract can also be given. The patient who are with good compliance or who are well educated, a short course of antimicrobial agent should be considered. They can self-diagnose that they are having an episode of recurrent UTI, and if they are well educated and with good compliance, they can self-treat themselves as well. The choice of antimicrobial is same as for uncomplicated UTI. Now, antimicrobial prophylaxis. As we all know that prophylaxis is that regime we should give antibiotic so that infection does not happen. It is not given after the infection has occurred, it is given before the infection have been occurred. So antimicrobial prophylaxis can also be given to manage a recurrent UTI. It can be given either as a continuous low dose for longer period, that is 3 to 6 months, or as postcoital prophylaxis in sexually active women. So the regime include nitrofurantoin 50 to 100 mg OD or fosfomycin 3 gram every 10 days. During pregnancy, cephalexin 125 mg or 250 mg or cefaclo 250 mg once daily can be given as antimicrobial prophylaxis. Now, asymptomatic bacteriuria. As the name suggests, asymptomatic bacteriuria is the urinary growth of bacteria in asymptomatic individual. That is, there is no symptom, and it is quite common. And most commonly, it is correspond to a commensal colonization. It occurs in approximately 1 to 5% of the healthy premenopausal women, while in 4 to 19% elderly female and men, and 2 to 10% in pregnant women. So the spectrum of bacteria in asymptomatic bacteriuria is very similar as it found in the uncomplicated or complicated UTI, depending on, of course, the presence of risk factor. Diagnosis is by means of a midstream sample of urine showing bacterial growth of greater than exponent 5 in 2 consecutive samples in women and 1 single sample in men. Cystoscopy and imaging of the urinary tract is not mandatory, of course, But if there is a history of medical or if we suspect any anatomical or urological abnormality caused, then we should do a workup. This is important. The asymptomatic bacteria does not need to be treated because it does not cause renal disease or any damage. But in pregnant women, we should treat this asymptomatic bacteria. Why? Anybody have any idea why we should treat asymptomatic bacteria?
There is a high risk of finding urethritis.
Yes, and
About 15% risk, 8 to 15% risk. So every asymptomatic bacteria in pregnancy has to be treated.
yes, and there is a risk of urosepsis and there is a risk of abortion as well.
Why there is high risk of
It is the complication of
There are a number of physiological factors. There is increased urine stasis because of progesterone. The ureter is bit dilated and the urine flow is not as fast. Besides that, pregnancy is an immunocompromised state. There might be some other factors. These two factors, what I remember.
So antibiotic should be given in pregnant women, and the choice we have is either the penicillin or cephalosporin. These are only the safe antibiotic for the mother and the fetus, and only short course of at least 3 days is recommended. So this is a flow chart as it suggests. If the patient present with lower tract infection, cystitis, and if it is a non-recurrent type of infection and uncomplicated cystitis, we should treat with empirical short-term antibiotic therapy. The repeat urine culture is not mandatory in uncomplicated cystitis, but if in pregnant women and in non-resolution of symptoms, we should repeat post-treatment urine culture. In cases of complicated UTI, we should give the specific antibiotic therapy, and we should further assessment by urine culture repeat and ultrasound KUB with post-void residual. So we should identify why the complicated UTI is happening. So workup after treatment is recommended in a complicated UTI, but is not recommended in uncomplicated UTI. And we manage appropriately, whatever the cause. In recurrent UTI, as I have discussed, it is important to work on the risk factor, that is the prevention of recurrent UTI. And prophylaxis can be given. And still, if it is not managed, then further workup should be given by us. Of course, we are the urologists. Now, some other causes of dysuria. We have discussed the UTI, and there are some other causes of dysuria as well. And the most common one is the urethritis. It is defined as the inflammation of the urethra. Urethritis is a sexually transmitted disease. There are two types of urethritis. The first one is the gonococcal urethritis, and the second one is the non-gonococcal. The gonococcal is caused by the Neisseria gonorrhea, and the non-gonococcal is caused by chlamydia, mycoplasma, trichomonas vaginalis, and ureoplasma urolyticum. The clinical presentation urethritis is very similar to acute cystitis, but it has a milder symptom and less quick onset. Many infections of the urethra are asymptomatic, but if there is a history of urethral burning or itching outside of the maturation, and if any history of mucopurulent or purulent discharge, then urethritis could be suspected. So, how we diagnose the urethritis? In dipstick, there is a sterile pyuria. That is, the leukocytes are positive, but urine culture is negative. So, for definitive diagnosis, we should send the urethral swab for the confirmation of the diagnosis. And a gram stain, if the gram stain of urethral smear shows more than 5 leukocytes per higher power field, it indicates pyogenic urethritis. And of course, on urethral swab, we should identify the organism, for example, the Neisseria gonorrhea, and we should confirm the diagnosis of urethritis. But now, recently, another test, the nucleic acid amplification test, are used in some laboratories, but it is an expensive test, and it is more sensitive and specific for urethritis, and it can also be done to diagnose urethritis and detect the chlamydia and gonorrhea in the first white sample, and is more specific.
So how many of you think that gonorrhea is common or it is rare in your practice?
This presentation is about the female you're talking about, males or females?
When we are talking about this, the whole population.
I've never seen in female or colleague that anybody has done urethral swabs. Not seen any paper. Single
It
test
should be
showing
done
that
or it should be
urethral
done.
swab has, sorry?
It should be done or it shouldn't be done.
What about, I've heard about chlamydia trachomatis, that is an extensive test. Extensive test when I was in gynae.
My
That
question
even
was
Agahan was not done. It is difficult to culture chlamydia trachomatis.
My question was different. My question was, how many of you have noticed that gonorrhea is common or it is rare? Starting from you, Naveen.
Sir, I have seen very lesser number of tests in the market.
Right.
So, majority are very much common.
Not that much common. You said it is rare, or it is rare. Ravi, rare.
We have seen.
So anybody of you who thinks that it is not so rare? Not rare?
Not rare.
Meaning to say we are not practically poking our nose into the subject.
One thing is that I think probably we're not thinking on these lines because there are many females who come with a negative culture.
Male or female?
Male or female, but I think the history is important.
But actually the vector is a male in gonorrhea. The female is just a bystander, the receiver.
And secondly, I think we're an institution. And secondly, these patients usually normally go to less institutionalized hospitals. I think probably the general hospitals in Karachi. So they'll probably be receiving more of the patients, and those that are very complicated, they don't come to us. So we need to have a spectrum that is outside SIUT. Then we can assess that how common it is.
You see, whenever you have got an impression in your mind that there is something which is not in your radar, it is going somewhere else. So probably your methodology is not correct. Your thinking or the catchment area in which you are working is not particularly looked into. For this kind of disease, you have to be proactive. This kind of discussion was done. A group of doctors. I was a part of that group. And a lot of our colleagues from military hospitals, they said that it is very, very, very common. Very, very means 90% of their personnel who happen to be on the borders, they have got this disease. Why? We can think about it. Why? But the problem is, if we are not trained to diagnose, if we are not trained to treat, then we will not be able to treat the population. So you have to be proactive in your treatment. So why it is very common in those people who are away from their homes. For instance, in bigger cities like this one, Karachi, where there is a larger population of migrants from other areas of the country. They are laborers residing in some quarters where there is no permanent settlement. They have got a very high percentage of this. So whenever you are standing in a clinic like OPD 14 on a Saturday or a Monday, you always see that these kind of people who have got a background of laborers and migrants, they have got this disease. So this is very common in those people who are in the madrasas. This is not taboing someone who is into the madrasa. They are away from their homes. You have to look into the whole dynamics of the population. It is so important, so much important that countries and cities like Dubai and Doha, Qatar, they have got a separate hospital for this kind of a disease. Why? Because there is a very high population of migrants, laborers, workers, daily wages. This is very common. So, yes.
It has become rare, but it's not that rare. At least there are 2 cases out of 800. I personally see them, and 4% of restrictors. It's got, but if we compare it with, for example, 50 years back, then or 100 years back, then most of 90% of restrictors were gonorrhea. And most probably the prophylaxis like use of condoms and early treatment because it's sensitive to every antibiotic. The incidence has decreased. But it's not that uncommon. So there are at least 2 cases I personally see in OPD in this years have been under average person made such.
Yes.
Hmm.
So it is not that uncommon.
Uncommon.
One of the most common reason of lower incidence might be awareness among the people because sexually transmitted.
Yes.
So the people who are living in larger cities, they more awareness about it, and the people who improve their hygiene and using protective measures are less likely to acquire this.
Yes.
So I think this might be the reason as well.
You see, it's a very interesting topic.
Personally, for educated people who are little aware about the use of condoms has decreased the incidence. And early treatment is under historical that we augmented better.
Yes.
So when partially treated and treated right. So early treatment with antibiotics they use or condoms may decrease case overall, but it's not that uncommon. It's not that.
So referring back to Naveen's observation, you see, 200 years back, or maybe 150 years back, it was so common that if you don't have it, so you are not considered to be either active or flamboyant or somebody who is younger.
Yes.
So you are not popular if you don't have venereal disease. But if you have it, then you become Casanova. So that's a word which is used for that kind of a person, and it is so common that in say Venice, Casanovas are here and then everywhere. But now the dynamics is changed. It is just the awareness is in the higher echelons, so that they are protected. But what about the lower echelons, the lower strata of the society? They are not protected. They don't use all these things. Maybe they can take antibiotic if there is some problem. Otherwise, this is an unprotected sort of say habit.
Yes.
And the thing is, once they are very restricted to a small quarter of say settlement, but now in Karachi at least, it has spread widespread throughout every part of the city.
Yes.
So now the GPs have got a different perspective. You as a tertiary care center has a different perspective. Maybe the military hospital has got a different perspective. So it's not out of the radar.
Sailors में जाता है. Sailors में.
Sailors. Okay, but it's the same thing. So out of your home,
Out of your home. So, what is the treatment? About broad spectrum empirical antibiotics should be started on presentation, and when the culture's result, it should be adjusted according to the culture. So, if the pathogen is gonococcal infection, ceftriaxone plus erythromycin can be given, and the dose is 1 gram intramuscular single dose or 1 to 1.5 gram per oral single dose. Alternative includes cefixime 400 mg per oral single dose and azithromycin again 1 to 1.5 gram per oral single dose. If non-gonococcal infection is suspected and it is unidentified at the moment, doxycycline 100 mg BID per oral can be given for 7 to 10 days. And if the organism is Chlamydia trachomatis, we can give azithromycin 1 to 1.5 gram per oral single dose. The alternative include doxycycline 100 mg BID for 1 week. If it is caused by Mycoplasma genitalium, azithromycin can be given with a dosage of 0.5 gram per oral on day 1 and 250 mg per oral from day 2 to 5. Alternatively, moxifloxacin 400 mg can be given for 5 days. If Uroplasma urulaticum is the organism, doxycycline can be given for 100 mg PID for 1 week, and the alternative are azithromycin 1 to 1.5 gram per oral single dose or clarithromycin 500 mg BID for 1 week. For Trichomonas vaginalis, flagell can be given in a dose of 2 gram per oral single dose, and if it is persistent, then 4 gram daily dose for 3 to 5 days can be advised. So the follow-up, it is very important in a patient with the urethritis.
Important है.
जी सर.
Partnership with people.
Yes sir, exactly. ये follow-up में ही बताया. जी. So it is very important to follow up the patient with urethritis because it is very important through sexual partner, as such suggests sexual partner should be identified, and if he or she has urethritis, he or she should be treated as well. And it is advised to avoid sexual intercourse for 1 week after the therapy is initiated, because it can transmit to the other sexual partner. And it is very important to report and trace the sexual partner so that they can be identified and properly treated. Genitourinary tuberculosis, another one of the differential diagnosis of sterile pyuria. So genitourinary tuberculosis should be suspected if we have sterile pyuria, and if the history suggests that the patient has a history of prior pulmonary tuberculosis, or he or she have any family member of having tuberculosis. So genitourinary tuberculosis can be suspected. The urine DR shows sterile pyuria. On urine analysis, acidic pH can be found, and he or she most likely have been given previous antibiotic, but the symptom has not been resolved. So diagnosis is confirmed by microscopic examination of urine by Ziehl-Nielsen stain or urine culture on Lowenstein-Jensen medium. But this urine culture takes 2 weeks to form, 2 weeks to report.
Anybody from the audience has seen positive AFP and PCR? Similar. Anybody has seen? Any experience?
Yeah.
ये diagnosis में बता रहा है ना कि microscopic examination of Ziehl-Nielsen stain, and
culture by
AFP and PCR. At least I have not seen any case coming positive with this smear and PCR. I have not seen. And whatever diagnosis of tuberculosis I have seen personally for biopsy, which is not recommended as the first line is not. But at least I have not seen any smear coming positive for AFP. Anybody?
What we have seen, I have seen at least multiple cases with AFP were positive, especially in scooter or skin diagnosis.
स्कूटर वाले ये यूरिन की बात हो रही है, यूरिनरी सेगमेंट में
I have seen cases. There are people they are present in functional urology. We have seen multiple cases.
कंफर्म करेंगे कि कोई पीसीआर की रिपोर्ट ऐसी देखी है जिसमें पॉजिटिव आया, मतलब आपने किसी का कराया और सस्पेशन ऑफ पॉजिटिव आया,
Urines are similar to that of PCR.
पीसीआर पॉजिटिव देखा है?
Similar and PS for
Actually, the AFP is made of positive treated and then follow it with the
नहीं आप कंफ्यूज कर रहे हैं ना, जैसे अगर आप कह रहे हैं AFP and CS, spare and CS is not PCR. PCR is
पीसीआर अलग है ना, यूजुअली आप पीसीआर करते हैं। बात है कि मैंने नहीं देखा, हो सकता है किसी ने देखा हो।
ट्रांसप्लांट में है सर,
ट्रांसप्लांट में तो हो सकता है, लेकिन ये हेल्थ पॉपुलेशन में जो है वो AFP समेत और AFP and PCR वेरी एक्सट्रीमली रेयर, पता नहीं मैंने नहीं देखा, हो सकता है किसी ने देखा।
बाकी तो सर एक और भी है कि हम लोग अगर शहर की बात करें तो वहाँ पे ज्यादातर लोग जो इम्यूनाइज्ड हुए होते, वैक्सीनेटेड हुए in the childhood. So if they have got this kind of vaccination, तो उसके अंदर थोड़ा सा dubious हो जाता है। PCR पॉजिटिव तो आएगा, लेकिन शायद वो डॉक्टर राणा के पास है कि वो उसकी जो एम्प्लीफिकेशन है, जीन एम्प्लीफिकेशन वो एक खास वैल्यू के से ज्यादा होनी चाहिए to make it positive.
अच्छा, दूसरी चीज ये है कि जो ट्यूबरकुलोसिस के पेशेंट है, ट्यूबरकुलोसिस के पेशेंट, उसमें ऑर्डिनरी यूटीआई हो सकता है और पेशेंट उस लोग जो है उसको ट्रीट करते हैं। सेकेंडरी इकोलाई या और कोई जैसे प्रोटीन है व्हाटएवर, तो प्रेजेंट हो सकता है ट्यूबरकुलोसिस के साथ एसोसिएटेड कॉम्प्लिकेशन सेकेंडरी इफेक्ट। हम लोग उसको ट्रीट कर रहे होते हैं, लेकिन वो भी एक कॉज है रिकरेंस का या नॉट रिलैप्स का। उसमें भी अगर आप देख रहे हैं कि आपने 6 हफ्ते का कोर्स दे दिया या व्हाटएवर आपने कोर्स दे दिया, ट्रीट कर दिया, फिर भी पॉजिटिव आ रहा है, तो उसको ट्यूबरकुलोसिस के लिए जरूर देखें, बायोप्सी के लिए, सिस्टोस्कोपी बायोप्सी या एएफपी व्हाटएवर उसको जरूर देखें। मेरे एक्सपीरियंस में इस तरह के पेशेंट हैं जिनको यूटीआई का ट्रीट कर रहे थे, लेकिन बाद में उनको वो ट्रीट नहीं हो रहा था एंटीबायोटिक से, फिर जब हम सिस्टोस्कोपी बायोप्सी की कोशिश की है at least वो
yes.
So the fraction is
very
So the treatment is ATT, anti-tuberculosis therapy. Another one of the differential is vaginitis. So vaginitis, as the name suggests, is the inflammatory condition of the vagina. And on urine DR, we can find the leukocytes are negative as well as the nitrite are negative, and the urine culture are also negative. So it is caused by Candida or Trichomonas species. The symptom, the patient can have a symptom of valvular itching, dyspareunia, and smelly vaginal discharge. So we should refer the patient to gynecologist for prompt or appropriate treatment of vaginitis. So we have discussed common causes of UTI. Apart from that, it is very important to identify the voiding habits of a female patient, how she is voiding. Because inappropriate voiding can cause voiding dysfunction, and voiding dysfunction can lead to bladder outlet obstruction or pretular damage and renal damage. So it is important to identify and correct the incorrect voiding habit. If the female is holding the urine for a prolonged period of time, that is more than 4 hours, in the 2 consecutive maturation, it is not appropriate. Prolonged holding of the urine is not appropriate because it predisposes to pretular damage because of the over distension of the bladder. So in order to identify this, we should offer the patient a 3-day voiding diary, and we ask her to chart her frequency volume charting. And with the help of that, we can objectively assess the patient urinary frequency and voiding and the voided volume. It should not exceed 300 to 350 ml. So these are the voiding habits in a female. You should address that as well. Yes, the last slide on this. On physical examination, as Madam has suggested, we do not do the physical examination appropriately, but it should be done to rule out any pelvic organ prolapse because it can lead to intravesical obstruction. An abdominal palpation should also be performed to detect enlarged bladder due to chronic retention. Urine culture should be done to rule out a UTI. Ultrasound KUB should be done to assess the bladder status, any stone, any diverticula, retrosal wall thickness, and kidney, the presence or absence of hydronephrosis. So, post-void residual, the expert has suggested that greater than 100 ml is pathological, and the post-void should be less than that. And if, in spite of all the measure, the symptom has not been resolved, then we can do the urodynamic testing. It is an invasive test, and it can help us to identify the cause and appropriate management like pelvic floor rehabilitation, CIC, sacral neuromodulation, and surgery for pelvic organ prolapse. So it's in that. So that's same we have previously discussed the things already. It's free examination, palpation, urine culture, and appropriate management.
Right.